Okay, I think we have to start. It's late and it's a difficult hour for everybody. So I'm pleased to introduce our guest speaker, Dr. Kathleen Kendall Tackett, who was kind enough to come from USA. Professor Kendall Tackett is a health psychologist, Leche League leader, and IBCLC. She received her bachelor's and master's degree in psychology from California State University and a PhD from Brandeis University in social and developmental psychology. She's currently clinical associate professor of pediatrics at Texas Tech University School of Medicine and clinical professor of nursing at the University of Hawaii. Besides that, she is the owner and editor-in-chief of Preclarus Press, a small press specializing in women's health. She is also editor-in-chief of two peer-reviewed journals, Clinical Lactation and Trauma Psychology, Psychological Trauma, sorry. She's fellow of the American Psychological Association and past president of the APA Division of Trauma Psychology. Dr. Kendall Tackett specializes in women's health research, including breastfeeding, and has won many awards for her work, including the 2016 Outstanding Service to the Field of Trauma Psychology Award from the American Psychological Association's Division 56. Finally, she has also authored 42 articles or chapters and 35 books. Okay, we all know that breastfeeding protects babies, but maybe many of you, they don't know that also mother is protected. So today, she will be talking to us about, does breastfeeding protect maternal mental health, the role of oxytocin and stress. Please join me in welcoming Professor Kathleen Kendall Tackett.
Thank you very much. I'm delighted to be here, and we've been having such a wonderful time here in your country, and so I'm honored to be here. I want to give a shout out to my friends from Leche League. We got Leche League of Ireland, Leche League of Greece. So, hey, you guys, thank you for such a warm welcome. 8 years ago, I took a picture with a whole bunch of Leche League leaders from Greece, and they said that one day they would bring me here, and they actually did, so it's really wonderful. I've got that picture actually up in my living room. It was a wonderful experience. Okay, so what I'm going to talk about today, I think you're going to find is going to tie into some of the talks that we heard earlier, and that is kind of looking at some of these sort of underlying physiology of what happens in breastfeeding and how that actually impacts a mother's mental health. You know, and we've got a lot of people out there right now saying it doesn't make any difference at all. But if you understand the physiology of it, you would realize that that is actually probably not the correct conclusion to come to. So the question we're really going to ask is this: does breastfeeding protect maternal mental health? That's the one we're going to ask. And so again, we've got a lot of people out there saying it doesn't make any difference. But I'm going to show you why I've kind of come to a different conclusion, and you can kind of see what you think. So, you know, this is a question that's really caused a lot of confusion for people. Because, again, I think part of it is we need to be very, very careful, you know, in our definitions. You know, I'm trained as a researcher. My graduate school that I went to was all research. So that's actually kind of the perspective I bring. I do work with mothers directly as an IBCLC. But I also, you know, am a kind of a hardcore researcher. And so it's like I find myself kind of looking at what does the science say? And the science on depression and new mothers continues
to interrupt you. The translators ask a little bit slowly. Thank you, sorry.
You know, I've heard that before. Okay, so this is the thing that we do see in the research, that breastfeeding women are less likely to be depressed. It does lower the risk of depression. Now, does that mean a breastfeeding mother will never get depressed? No, it definitely does not mean that. What it actually means is that it lowers the risk, just in the same way that we say it lowers the risk of breast cancer. But we've probably all known women who have breastfed who have also gotten cancer. But what you see is just a lower rate. And what you also see is that if women are depressed, breastfeeding can help them cope until they get better or while they recover. Okay, so a question I had somebody ask me recently was this: aren't breastfeeding mothers just healthier to begin with? Is the reason that we're seeing lower rates of depression in breastfeeding mothers because they just aren't depressed to start? That they're healthier and that's why they made a decision to breastfeed? And some of that actually could be true, because we're going to actually see that, in fact, depression itself is a direct threat to breastfeeding. And it's one of the reasons why I spend so much time talking about it to lactation professionals, because it is something we need to really be on top of and evaluate for mothers. And it's not necessarily that we're going to treat them, but we need to be aware of it because it actually can stop breastfeeding. So that question about are they just healthier to begin with, there is some truth to that, but it's not all that. Okay, so one of the things that is very important to tease apart is, what do you mean by breastfeeding? Because again, many studies that aren't really familiar with breastfeeding, they put everybody in this group of breastfeeding. They put you in there if you're having pain. They put you in there if you're partially breastfeeding and if you're exclusive breastfeeding. So if you group all those moms together, you're going to find that there's no difference. But the important thing is exclusive, because that's where you get the biggest physiological effect. We have found that exclusive breastfeeding actually is a different physiological mechanism that protects women's mental health. Okay, so what we're going to look at today is that relationship between the stress and oxytocin system. We're going to also look briefly at the impact of birth interventions and how it impacts that system. And we're going to look also briefly at maternal infant sleep, because this is really important for you to understand, because sleep directly impacts maternal mental health. And we know that exclusive breastfeeding changes the nature of sleep, and it changes it in some positive ways. So let's first off start by looking at the stress and oxytocin systems. And what you're going to see is these systems are kind of in a relationship with each other. And so when one is high, the other is low. And so the important thing is to make sure that the good system, the positive system, is the one that's up, and not the stress system, which is not supposed to be chronic. And that's actually the thing that causes depression. Okay, so we can talk about the stress response, and this is kind of the key to understanding this, in terms of 3 different kind of reactions. Now, a couple of these are going to be really familiar to you, and the other, I think, is going to probably be less familiar. Okay, so the first reaction, or part of the stress response, is when we are under threat or danger. There's a reaction called the Catecholamine Response, which is known as the fight or flight response. And so, as the name implies, it's to help you either fight your way out of the situation, or run away, get out of there. In some cases, it's also a freeze response. You see that a lot in people who suffered trauma as children. Oftentimes that freeze response gets activated. But it's a survival mechanism. It's supposed to keep you alive. That's what it does. Okay, so about 20 minutes after threat exposure, another system kicks in, and this is called the Hpa Axis. And I'm going to talk a little bit about what that means. But this is where you get the stress hormone cortisol. Okay, so when we were talking about hyperinsulinemia this morning, having high cortisol causes hyperinsulin. So the things that we heard about in this morning's session about all the problems with metabolic syndrome, when cortisol levels are chronically high, that's one of the systems that actually activates that. Okay, now this is the part that might not be as familiar, and that is the research from psychoneuroimmunology. And what they have noted is that also in the stress response is our bodies activate inflammation. And so it's these inflammatory molecules that we know that directly are related to depression. The higher your inflammatory molecules, the more likely you are to be depressed. And inflammation and depression actually feed each other. So when you're depressed, you make more inflammatory molecules. And if you have more inflammation, you're more depressed. And they actually know that there's a causal link, because they've done studies where they've actually given people these inflammatory molecules as chemotherapy. And they find that the more they give, the more depressed you are. When they start tapering the dose down, you become less depressed. So this inflammatory response system is actually a key to understanding the mechanism for depression. When this system gets activated, this is actually what leads to depression. Okay, so understanding that is kind of like the key to this, understanding the stress response. Okay, so just to go into a little more detail, when you talk about the catecholamine response, you have these 3 neurotransmitters that get activated. And we've especially done a lot of research on looking at the relationship of norepinephrine, or noradrenaline. The Hpa axis, this stands for hypothalamus pituitary adrenal axis, and it's a sort of what we call a cascade response. So it starts in the hypothalamus, a little structure in the middle of the brain, that actually secretes a stress hormone that's called either CRH or CRF, depending on who's writing the article. Okay, and then CRF isn't, that triggers the pituitary gland then to secrete another stress hormone that you see, which is called ACTH, which causes the cortex of the adrenal gland to then secrete cortisol. So it's this three-part response is the Hpa axis. So again, the important thing to know is the stress hormone cortisol. Now, our inflammatory molecules, we can characterize these as our badass soldiers, because that's what they do. The inflammation molecules, the reason they're activated and they're part of that stress response is because when you're in danger, okay, when your body feels threatened, the inflammatory molecules fight infection and they heal wounds. So you can think of them as your soldiers. And the soldiers actually get in there and, and will fight infection and heal wounds because they're perceiving danger. Now the problem is these soldiers should not be activated all the time. Now the ones you tend to see that tend to be high in depression, so people who are depressed tend to have high levels of these three hormones. And these are just molecule names, IL-1 beta, IL-6, and TNF-alpha. Now, the way that they actually research this is they actually give people paper and pencil test measures of depression, anxiety, post-traumatic stress disorder, hostility, a lot of different constructs we know they're related. And then they actually draw their blood and look at the plasma. And that's how they measure these molecules. So we know that there's a very strong relationship. There's hundreds of articles on this. The reason you've probably never heard about it is because the people who do this research are a bunch of nerds. They go to their own conferences, they have their own journals, they never talk to anybody else. And so what we find is actually these pro-inflammatory, this is so key to understand because it helps explain mechanisms. For example, depression is a risk factor for heart disease. Okay, now we've known that association for a long time. It's the psychoneuroimmunology folks that actually gave us the reason, the mechanisms, and it's these molecules. When these molecules are chronically elevated, you get disease. Okay, we know that chronic elevation of inflammation actually damages blood vessels. It actually causes clots. It's been associated with things like cancer and Alzheimer's. So there's many, many, many studies that have actually shown that association. So they're telling us the mechanism. We see the association. Psychoneuroimmunology gives us that sort of line between the two. Okay, so one thing that's really important to know is that when you're pregnant, your pro-inflammatory molecules rise naturally in the last trimester. And the reason is, if you think about it from the body's perspective, the body is anticipating having an open cervix for 6 weeks. So it makes sense that you're going to get your soldiers ready so there's no infection. But if you have the normal rise in elevation and you add stress and you add trauma and you add sleep problems and you add pain, all of a sudden you've pushed that normal level of inflammation into the abnormal range. Okay, so that's actually a time that's really vulnerable for women. And in fact, it is actually when women's risk of depression is actually highest. It's the highest in the last trimester. Now it's also high in the postpartum period, but it's actually higher in the last trimester of pregnancy. So it's important that we also know that. Okay, so the structure we kind of got to talk about, and again, it's not nearly this big, it's a tiny little structure. This is a part of the hypothalamus, and this is just the approximate location, but it's called the Paraventricular Nucleus, or the PVN. Now the PVN is the structure that actually governs which of the two responses are going to be activated. So oxytocin and the CRF, which is part of the stress response, work in a relationship to each other. It's almost like a toggle. So when one is up, the other is down. Okay, so what we want is activation of the oxytocin system, and that turns down the stress system. But it can go the other way around. When the stress system is activated, which it is underlying depression, then oxytocin is down. And if oxytocin is down, it's going to cause breastfeeding problems. So it's kind of easy to understand why women who are depressed often give up breastfeeding, because it's difficult for them. Okay, so when you have the stress response activated, the CRF, you get stress, you get activation of the Hpa axis, the sympathetic nervous system, and inflammation. But you can go the other way. You have oxytocin. If oxytocin is the dominant one, then you get relaxation, it activates the vagal response, and it activates the parasympathetic nervous system. Okay, so that's the system that actually leads to long-term health. Okay, so how is this related to maternal mood? Well, again, going back to that question of, are mothers just healthier to begin with, and they're the ones that are breastfeeding? Well, we can actually answer that question by a couple of different types of research. You can first of all look at a prospective study. So in a prospective study, what you do is you actually enroll women at the beginning. You assess them, and then you follow them. Okay, so everybody's not depressed at the beginning, and then you follow them for 3 months or 6 months or a year, and you see how they're doing. And that actually can tell you a lot about whether women are going to be depressed related to breastfeeding. Because if everybody starts out not depressed, and then there's a difference at the end, you know that there's something going on with the breastfeeding. Okay, so non-depressed mothers to start, you compare them by feeding method. We can also look at the physiology that changes when you're talking especially about exclusive breastfeeding, particularly looking at the inflammation and the activation of the Hpa axis. And we can also see what it does to sleep, because we know sleep is specifically related to depression. Okay, so here's an example of a prospective study. I thought this one was a rather nice one. But you can see a large sample of moms, and they followed them. They enrolled them during pregnancy and followed them to 3 months. And they found significantly lower Edinburgh depression scores. Okay, so that's the EPDS, is the Edinburgh Postnatal Depression Score. Significantly lower at 3 months for the exclusively breastfeeding mothers. Remember, I told you that's the difference. There's a difference between the exclusive and the partial. And they said even after they controlled for other factors, they still found that. This was another nice study. This was done out in California. And they also found that women breastfeeding at 3 months had significantly lower depression at 24 months. But it made a difference how many times a day you breastfed. So it goes back to that issue of exclusive versus partial. So you found the effect if women breastfed 9 times a day or more versus 4 times a day. Okay, but if they were depressed during pregnancy, it made them less likely to breastfeed. So again, remember I said that depression itself can be a threat to breastfeeding. Okay, and they tended to actually wean earlier. Okay, now this study actually didn't find a difference in depression scores, but they did actually find some interesting things in terms of the physiology. Okay, they found, like different profiles in terms of the cortisol and the IL-6 in what they called the predominant breastfeeding group. So again, we would predict that this group would actually be less likely to be depressed eventually because of their physiology. This study I thought was actually very interesting. This was done in Germany. And what they did is they brought mothers into the lab and they stressed them. They actually got them, and they would do things like do a mock interview. Or like if I pointed to you and said, come up here, we're going to sing. Your stress level probably just went up when I said that, right? So they would do things like that to the moms. And they were comparing mothers just holding the babies versus babies actually suckling at the breast. And where they got the best protection was the suckling at the breast, because not only are they getting the milk ejection and oxytocin from that, but they're also getting it from the skin to skin. So that's the best protection. And again, it's something important to kind of think about when you think about, moms whose babies can't be at the breast. We got to think about what other things can we do to lower their stress. But what they found is after the mothers breastfed, it lowered their cortisol levels. It also lowered ACTH, remember one of the other stress hormones. Now, when they tried to stress them after they breastfed, they found that they couldn't because they had this lovely little cloud around them, okay, afterwards. And, don't mothers tell you that? Probably many of you have experienced that. The world is falling apart, and you sit down and nurse your baby, and suddenly it doesn't seem so bad. That's adaptive. That helps us survive. That helps us actually be mothers and get through some of the tough times, doesn't it? Okay, and so then they found overall that each time they breastfed, it provided a lessening of the short-term stress response. Okay, so even when they tried to stress them, they couldn't. Okay, and we also know in this study here that breastfeeding lowered also ACTH and cortisol, and especially the skin-to-skin was an added part of that. Our skin is a very important sensory organ, and skin-to-skin contact is a very powerful way to stimulate oxytocin. It's actually more powerful than actually milk ejection. And also, too, that the more a baby suckled at the breast, lower ACTH, just like what the study in Germany found, and longer skin-to-skin lowered cortisol. So again, even when moms have a very stressful birth, if we can get them skin-to-skin, oftentimes that will lower their stress levels. Okay, and they actually said that it was oxytocin that was actually specifically lowering the stress. Now, what's interesting is how this impacts women long-term. Because I have people sometimes in the U.S. and they say, well, you only care about the baby. I actually had somebody at a conference at one time say that to me. She said, you care about the baby, but we care about the mother. It's like, no, I care about the mother. The mother and baby are a unit. They are a package. I care about them because, you know what? Breastfeeding benefits the mothers as well. And this was an interesting study. You can see here the mean age is 63. Okay, so I think we can assume that it's probably been a little while since they've lactated, right? Although every once in a while I met somebody one time and had her one and only baby at 68. I have to say my curiosity completely overcame my manners. So I had to ask her about that. But she actually qualified for both Social Security, which is what we have for our older people, and our WIC program, which is for pregnant and expecting mothers. So the only person I think who qualified for both of those. Okay, but you can see what's interesting about this is you think about this has been a long time since most of these women have breastfed. And yet, lifetime protection from the #1 killers of women. Okay, it lowered their triglycerides, lowered cardiovascular disease, lowered diabetes, and lowered hypertension. Okay, so huge sample, and we saw these significant lifetime effects because during the time they were breastfeeding, it was turning off that stress response day after day after day after day. There's a cumulative lifetime effect that protects the health of women. Okay, so you can answer this question now. Thinking about those two systems and which one is upregulated, are we going to see the same effect if the mother is in pain? What's going to happen to her? Is she going to be at higher risk or lower risk of depression? Higher, absolutely. And so this is one reason why you can't include these mothers, in these samples, because they are at higher risk for depression. It's one reason why I think we have to address this immediately. There's a lot of things on Facebook going around where people say, oh, it's really painful for the first month, but just hang in there. And it's like, no, if there is pain, please go talk to somebody. And I was arguing with one of my authors one time because she wanted to put that in. And she said, oh, yeah, that's what my experience and all my friends. And I said, please go talk to a lactation consultant. And she came back and she said, well, we talked to a lactation consultant, and she said the baby had sharp gums. At which point I want to bang my head on the table. I mean, there's this idea sometimes, at least floating around in the United States, that the breastfeeding pain is normal. It is not normal, and it will increase her risk of depression. Okay, so let's talk a little bit about the impact of birth interventions. And this is something I'm actually very, very interested in. And we actually now have a lot of research on this, and I'll show you some of our research as well. But to show you just a couple studies, this is one from the UK, which I think was a very nicely done one. And one of the things they found is, first of all, we're going to look at breastfeeding problems, and then we're going to look at depression. Because you'll find where there's breastfeeding problems, there is often depression. They kind of go together, and you see them coming up in study after study after study. So in this study, they actually were looking at breastfeeding problems and found more breastfeeding problems if women had either forceps births or unplanned cesareans. These actually interventions were all related to breastfeeding problems of all types, including they impacted women who were doing any breastfeeding and exclusive. So these labor interventions do actually make a difference. It's not to say never use them, but I think the thing we have to be aware of is they actually can have a negative impact, and we can't sit there and pretend like they don't. It's like if we use them, then we have to know there's always this sort of risk-benefit thing. I actually had somebody criticize one of our papers, and he said, well, I use epidurals all the time, and they are fine. The guy's an anesthesiologist. He never sees the women again. You know, it's kind of like I want to say define fine. What do you mean by fine? You know, we got a lot of research on this now. Okay, now this was a nice prospective study. Remember, so they enrolled women before they gave birth, and they found that epidurals were associated with either partial breastfeeding or breastfeeding problems, and they were twice as likely to stop by 24 weeks. So again, you know, this is in a country where the breastfeeding rates are very high. You know, but, you know, it's not completely clear. Hang on, go back here. What we actually see, this was a review from the Journal of Human Lactation, and you can actually see that a couple of the studies, actually 10 studies, showed that there was no effect on breastfeeding. But, you know, 12 did show a negative, and one actually said there was a positive effect. You know, so I said there was one study from China that had a positive effect, and people were very excited about it. Okay, so I want to talk a little bit about some of our data. And you can see we've got a very large sample here. So we had 6,410 moms. They represented 59 countries. To be in the study, they actually had to have a baby 0 to 12 months old. They ranged in age from 13 to 50. We had a big range. They were predominantly, at least by education level, middle class. Okay, and that's going to kind of be important when we look at some of this stuff this afternoon, when we talk about the violence. Okay, so the first thing to look at with this is, and I'm going to make sure I use my microphone. Oh, I like that in the green. That looks nice. Okay, you can actually see there's a very big difference if you have a vaginal birth versus any other types in terms of rates of exclusive breastfeeding. You know, I think that that's actually pretty clear. So anytime there's any intervention, it does tend to lower the rates of exclusive breastfeeding. Okay, and we also looked at the impact of epidurals. Okay, so you can see exclusive breastfeeding is actually quite a bit lower if a woman said she had an epidural. Okay, versus, you know, there's mixed feeding, and that's exclusive formula feeding right there. Okay, and the pain medications, this is actually using opioid pain medications. You can see that really had a negative impact on exclusive breastfeeding rates. Okay, and so what about depression? Where does depression fit in? Well, you know, there's been a few studies on this. You know, this one here, I don't think this is a very huge surprise. If women preferred a vaginal birth and they ended up with a cesarean, they tended to have higher rates of depression. This was a study actually from Hong Kong, and they were looking at elective C-sections. Now, I want you to take a look at those rates of depression and anxiety. Those are very, very high numbers, aren't they? You know, again, I think sometimes people don't understand that, you know, this stuff has an impact. And, you know, I think for a lot of times, you know, we have these TV shows where a lot of times women think, oh my gosh, I don't want to go through all that screaming, sweaty labor. I'm going to just have an elective C-section. And, you know, I think you got to realize there's a cost to that. Okay, and we found actually a very similar thing. Now you can actually see here, this I have to admit was honestly a surprise. Our planned C-section group actually had the highest depressive symptoms. Okay, so no trial of labor, they went in for just a C-section. I thought this group was going to be the highest, emergency C-section. Okay, but it wasn't actually. This was the second highest. But you can see the rest of the groups are actually pretty low. This one I thought was actually really interesting too. I thought there was something wrong with the data, to tell you the truth. It was unplanned C-section, but not emergency. And look at how low their depressive symptoms are. And so I kind of went in and took a look, and there were like 500 mothers in that group. And so I thought, okay. So I started kind of thinking, what could it be? You know, and I started thinking about women that I have known over the years, and they said, you know, like for example, they go in and they're gonna have a VBAC, a vaginal birth after cesarean, and they're in there and they've got their support people and they're laboring, they're doing labor, and then finally somebody, you know, they all decide, gee, this is not progressing, we'll go ahead and do a cesarean. So they feel okay about it. But they still have the cesarean, but they felt like they were involved in the decision, they were supported, and they had their trial of labor. So I think that explains this group here. If anytime you're in an emergency, this is going to trigger, you know, like post-traumatic stress disorder. You know, if you feel like you're going to die, your baby's going to die, that's going to trigger a PTSD response. Okay, now I pulled something up here weird. Hang on. Okay, so let's go on to this one. Now, there was a conversation this morning about what happens when you use synthetic oxytocin. This was actually a really interesting study. Kirsten Uvnes-Moberg and I wrote a review article about this for the blog Science and Sensibility, because they were wondering about this, this data. And you can see a very large sample. It was a population data set. And their hypothesis was really kind of funny, because what they actually thought was that, they thought, okay, well, oxytocin is the happy hormone. And so that if women have oxytocin during labor, for either to, induce labor or to, augment it, or if they have it in the immediate peripartum period, so like, for example, to stop bleeding. They thought, well, if they've got this synthetic oxytocin, they should be happier. They should have less depression and anxiety. And again, like I said, I kind of had to wonder. I think that these were people that had never studied birth before, because when you have synthetic oxytocin on board, you have a lot of other interventions, don't you? Yeah, and so somehow they kind of had this hypothesis. The other thing is, synthetic oxytocin is peripheral. It never gets into the central nervous system. So it doesn't impact depression at all. And so here's what they found, and they were very surprised. They said, contrary to their hypothesis, if women had a history of depression and anxiety, it increased their risk by 36%. Okay, and even if they didn't have a risk, it increased their risk by it was 36% if they had a history and 32% if they had no history. Okay, so that's a substantial increase. So it didn't make it better for them, it made it worse. And again, like I said, I think part of it is because when you have oxytocin on board, you have more interventions usually. Because you can't have you usually don't have oxytocin without having an epidural, and sometimes that leads to labor stalling and then you end up with a C-section. Okay, so one study, actually this is the one I mentioned from China, everybody got very excited about it. They found that epidurals actually lowered the rates of postpartum depression. So everybody was rushing in to explain why this could be. Maybe women had better labors, they felt better about them. But then I went and actually read the paper, and take a look at the sample size. 15 mothers with an epidural and 37 without. Okay, that's interesting, but I wouldn't base any policy on that. It's just too small of a sample. Why are we even talking about this? But it made international news. Everybody was very excited. Okay, so this is actually what we found. Going back to our data, looking at the 6,400 moms. First I just analyzed it just straight, sort of bivariate analysis. And I looked at depressive symptoms and did they have an epidural? Yes, no. And you can see substantially significant. It was, 0.0001. Okay, so big difference. But then, people kind of said, well, yeah, but what about this, could be lots of other things contributing to that. So we said, okay, let's control for those. So we did. We controlled for all the other birth interventions. Because again, an epidural could be a marker of a lot of other interventions. So we actually statistically controlled for all of those. We controlled for whether they were first-time mothers or whether this was, they were multiples. They'd had more than one baby. We controlled for how many hours they were in labor, their income and their education. Both of those were highly related to depression, by the way. Another thing, very highly related. We controlled for their history of depression. We controlled for their history of sexual assault, big predictor of depression. Their current level of anxiety and their current level of anger and irritability. And we still found 3 interventions related to depressive symptoms. Postpartum hemorrhage, postpartum surgery, and epidurals. So, this was the study actually that anesthesiologist didn't like, but I thought, we controlled for a lot of the other factors that could explain our findings. So what is the biological explanation for this? And I'm going to actually pull this graph up and I'll kind of try to talk you through it. Okay, so I want you to kind of think about it this as sort of 2 basic systems here. Okay, so over here on this right side, think about that as normal labor, normal physiological labor. And things are progressing. They're painful, but they're manageable. And one of the reasons why they're manageable is because the baby's head is pressing on the cervix. And that's releasing oxytocin, something called the Ferguson response. So it's releasing that the baby's head on the cervix is releasing oxytocin. Okay, so with normal contractions, yes, they are painful, but they're manageable because it's releasing oxytocin. And it's activating that parasympathetic part of the nervous system. Okay, so it makes it so you can cope. Now over here, let's say you have an abnormal labor. So let's say you add something like Pitocin. So instead of having sort of 3 contractions at a time, that come in short intervals, it's 10. Because one of the problems with Pitocin is it makes the contractions don't just kind of gradually go up and down. They hit you full force. They come up and they stay up, and then they go down, and then they hit up. And so they're very, very painful. And that's one of the reasons why most women have epidurals with them. Okay, so very painful over here. So what that is doing is, first of all, it's blocking this part. It's blocking the oxytocin, that incredibly painful. So you got synthetic oxytocin over here, but it's blocking natural oxytocin, which is the one that really makes a difference. Okay, so the sympathetic nervous system is activated. That's triggering the whole stress response. And it's also sort of blocking that oxytocin response. And so then it makes it much more painful. And you get into that very bad pain cycle. And that's about the time that somebody will actually have an epidural, because it really becomes intolerable. Okay, so what do epidurals do? Well, first of all, they definitely cut this. Okay, so they make it not painful. But they also cut this. And so they cut that naturally occurring oxytocin. So this is actually, I think, a probable mechanism by which oxytocin, or by which an epidural can actually lower natural oxytocin, which increases the risk for depression. Okay, because it cuts both. That's the problem. Now, some interesting things about this too is, like, if you're looking at this side over here, one of the things that really actually makes a difference is wanted touch. So it's somebody that the mom trusts, that the mom, feels connected to. If that person is touching the mom in a supportive way, that is a huge way to get oxytocin. And it's one of the reasons why I think about doulas, why it helps them cope with labor. It helps moms cope with labor, is because what are they doing? They're in there touching the mom, and it's releasing oxytocin, and it's activating this side of the scale. Okay, so again, you sort of go through and cut that, you're going to actually increase the rate of depression. Okay, so we do know that breastfeeding is related to, depression does lead to breastfeeding cessation, as I've mentioned. We've seen that in a couple of different studies. This one here was looking at the combination of depression and low support leads to weaning. I don't think that's a big surprise. This one here from Britain, this one actually got a lot of press. It looked at the mom's intention to breastfeed and whether she was able to. And again, what many reporters, I talked to several reporters about this, and what they interpreted this to mean was we shouldn't pressure moms to breastfeed. And I said, well, there's another way you can look at this. This group up here that intended to breastfeed but did not. Perhaps the issue is, did they not have enough support? We put this expectation on them, they wanted to do it, but they didn't get the support they needed out in their community. And maybe that's the issue we need to really address. Okay, now this was actually kind of an interesting one. It was they found more depression if the mothers had not intended to breastfeed, but did. And I could not for the life of me find out how many moms that included. Because I couldn't even think about a circumstance where that would occur. But somebody said, yeah, but maybe she's getting a lot of family pressure. And I thought, okay, that makes sense. We also know anxiety tends to actually increase the risk of stopping breastfeeding. I think that's probably the big role of breastfeeding support is we can calm anxious moms when they're worried. They're worried they're not making enough milk. They're worried this. We can just say, hey, this is how you tell. We think you're doing great, and they're reassured. But if they don't have that, it could spin into, I know I'm starving my baby, I'm doing it all wrong, I'm doing the wrong thing, and then they stop. And right around then, of course, that's when the formula samples show up on their door, right? Okay, and if you look at this study here, this was like looking at depressed moms and their reasons for stopping breastfeeding. And these, to me, look like lack of support. That they still had to do too many things around the house, that it was painful, that it was tiring. And again, I think sometimes, we don't hear moms when they tell us that. I noticed that when we were doing this special issue from the journal on tongue tie, the stories that, we had moms share some stories, and that was kind of one of the themes. It hurts, the baby's on all the time, and everybody just kept saying, yeah, but it looks fine, and we're not listening. And I think, especially when a mom's telling us all the time how tired she is, I think we need to ask a couple more questions and find out what's going on. Or her breasts were overfull or engorged. I mean, these are all breastfeeding management problems. Okay, and again, like I said, even things like high-risk pregnancy can sort of trigger a depressive symptom. But this was, I thought, very interesting. Look at this. If there were supportive hospital practices it increased the odds of exclusive breastfeeding by 2 to 4 times. So I think what you can say from this is support makes a difference. Okay, so I think one of the things to think about when we talk about some of this research, looking especially at that sort of stress versus oxytocin effect. Okay, we're seeing in the literature, like people who have a history of trauma, and we're going to talk more about that this afternoon. People have a history of trauma, or they have, prior depression, or they had a lot of birth interventions. Their oxytocin levels are going to probably be lower. Particularly if they had a planned C-section, we know that they didn't get that oxytocin from the Ferguson response. And so I think what happens a lot of times is people just give up. And they say, well, I guess this woman's not going to be able to breastfeed. And I think actually that's kind of a rubbish argument, you want to know the truth. I think what we need to be saying is, let's increase oxytocin. How do we do that? Well, there's some ways we know that work. Okay, skin-to-skin contact, it works. Now, I will put one caution to that, because the only thing that we do know is that skin-to-skin contact for women who've experienced trauma can sometimes be a little too intense. So we may have to be a little more gradual with how we expose them to that. But skin-to-skin contact, touch, triggers huge amounts of oxytocin. Having positive social interaction, and that's something so important. So it's really important that mothers get to pick who's with them in the labor and the postpartum period. They need to have people that they feel good about, around them. And so, they might have a relative who's standing there and being really negative. That's something that we need to protect against. And also, this is critical. They have to feel safe. If they don't have that, feeling of safety, it's going to trigger that fight-flight response, okay? And then it's going to increase their risk of depression. It's going to lower that oxytocin level, okay? And also, warmth is really helpful. Sometimes having like one of those, things that you put in the microwave that you put around your shoulders, that can really be a nice thing. Or, having one of those things where you get your feet soaked in a nice warm bath of water, that all increases oxytocin. And these are things that moms can do. Okay, so I'm going to very briefly talk about sleep. And yes, I'm keeping track of the time, Nikos. For one thing, this was a nice study this was actually published in the journal Sleep. Okay, so this was actually this is a sleep medicine journal. This is not, some warm, touchy-feely attachment parenting kind of journal. This is a sleep journal. And what they found is that, first of all, with looking at this sample of 2,800 moms, that if mothers were sleeping poorly, that it was a risk factor, a strong independent risk factor for depression. But here's the things that they found that were associated with poor sleep. And actually, I have a whole other talk on this, and so, I've got some handouts on this on my website if you want to take a look. But some of the factors associated with poor sleep included if they were depressed. Depression changes sleep, okay? And sleep problems make you more likely to be depressed. So if you are depressed, chances are you're going to have poor sleep. If you've had previous sleep problems, that's not a surprise. First-time moms oftentimes had harder time. Having a younger or male infant. And here, look at this one. Not exclusively breastfeeding. The women who were not exclusively breastfeeding had poor quality of sleep, which led to depression. Okay, this is what the sleep medicine researchers are finding. Okay, so here's what we found in our study. This was actually looking at the 6,410 moms. And I have to admit, this was a surprise to me. I always assumed exclusively breastfeeding mothers got less sleep. I assumed that. And what I found was exactly the opposite, and this is what at least 4 other studies have found. Okay, look at this. They pointed 6.61 hours of sleep. And what was interesting about all of the data in this particular set is there was no significant difference between between mixed feeding and exclusive formula feeding. That those two had the same effect. And so it was only exclusive breastfeeding that made a difference. And I have to admit, that surprised me. Because if you look at that data, it looks more like a dose-response effect, doesn't it? That the more breastfeeding you got, the better. That's not what the statistics told us, that there was a difference. That's a threshold. So basically, exclusive breastfeeding is a physiologically different entity than partial feeding. At least in terms of the protective effects on mother's mental health. That was also translated to things like her daily energy. And I want to just say one thing about this. This is actually a 5-point scale. Because I have sometimes people say, oh, I breastfed and I was tired. Okay, this is still postpartum. This is not, you know, a walk through the lilac patch, is it? Okay, but the question is, would you be more tired if you started supplementing? And the answer is yes, you would be. Okay, so you're still tired, but you'd be more tired. And isn't that always the thing? When a mom is tired, that's the first thing people suggest. Give the baby a bottle. That's going to make you more tired. And it lowered their risk of depression. So what can we conclude? First of all, I think we can make a very strong argument that breastfeeding does protect maternal mental health. But it's exclusive breastfeeding. And it's not breastfeeding with problems. That can actually cause depression. Okay, so the best protection for mom is exclusive. Now, if a mom is partially breastfeeding, I never want to discourage that. Okay, sometimes moms, that's all they can manage to do. But if we're talking about the protective physiological effects, where it is at is with exclusive. Okay, and then breastfeeding problems can cause depression, and that's one of the reasons why, you know, we obviously, all the support that you give moms is really probably helping prevent a lot of depression. Okay, and so the apparent contradictions in the data, you know, when you talk about, okay, well, breastfeeding, you know, depression is more likely to lead to breastfeeding cessation over here, and then yet it lowers risk over here, but not for everybody. It's like when you put all those studies together and you map them on the underlying physiology, especially looking at that relationship between the stress response and the oxytocin response, if you put all of that together, okay, then the apparent contradictions in the literature actually go away. Okay, and it's important to also say that birth interventions impact both breastfeeding and maternal mental health. And it's not to say we never use them, but let's not pretend like they have no effect, because they do. Okay, and it's also important that if you have a mom who is depressed, she absolutely can breastfeed. You know, something that may be a little bit harder for her, but she can do it. And so many mothers tell me that they've been diagnosed with depression and the doctor told them to wean. You know, that was the phone calls I used to get from the Leche League all the time. I found out actually that the Leche League in the U.S., their national hotline for the whole country, every time a mother was calling and she was saying she was depressed, they were getting my home telephone number to give me a call. So I've talked to lots and lots of mothers. And yes, they absolutely can. And so many of them said, this is the only thing that is going well for me. Okay, so don't give up on these mothers, even when they have risk factors. You know, and that includes some of the things we're going to talk about this afternoon when we talk about violence. And the other thing is, let's think about increasing oxytocin. You know, even if moms have come into the postpartum period with lower oxytocin because of previous risk factors, we can increase that. Okay, so what we're going to do is we want to tip that other part of the scale, so they're the oxytocin side and not the stress side. Okay, so with that, I'm going to wrap up. I just want to mention, I do actually have a new edition of Depression New Moms, if you're interested in this. It is available from Rutledge in the UK, and they ship free, if you're interested in that. Just give a little shameless commercial there. Okay, my publishing company, we have a lot of depression books. So again, if this is a topic you find interesting, we do also have a distributor in the UK who will ship here. Okay, and so these are my social media accounts. So you're welcome to shoot me an email. I'm happy to answer. I'm not always super fast at it, but I will answer. And with that, I think we have 7 minutes for questions. So does anybody have any questions, or do you need a little break? Oh, yeah, wait for the microphone so they can hear it back in the booth.
First of all, congratulations on what you said. It's exactly what I wanted to hear.
Oh, I'm glad.
Because I was studying about synthetic oxytocin and its effect on mothers and babies. And I've recently read that there are some data that show that mothers that received synthetic oxytocin had lower levels of their oxytocin even after weeks. So yeah, there's also a feedback mechanism. It's not that even though it cannot get in the brain, it somehow regulates the internal oxytocin and the receptors.
Yeah.
So there is a connection, but they still haven't got the data to prove it.
And, what's kind of interesting is, synthetic oxytocin does kind of have its uses. Because remember we talked about the planned C-sections, and they don't get the oxytocin from the Ferguson response. They've actually found, in that case, administering oxytocin to them in the postpartum period is actually helping. Yeah. Because one of the things Kirsten found in her research, which just absolutely blew me away, she said that when they were putting those mothers skin to skin, the ones who had planned C-sections, not as much of an oxytocin. So their synthetic oxytocin can help, but it does make it difficult in labor, there's no question.
And I also wanted to add, in those studies that showed that there is no negative effect of epidurals, they have, most of them have control groups that did receive other medications. They had low doses that may not have an effect, or they had lactation consultants that helped the mothers so that it didn't have problems afterwards.
No, you're absolutely right, and also there's all kinds of things with epidurals, like especially what drug was administered. Fentanyl seems to be particularly bad, but also, I think you're right about that. That those happened in a baby-friendly hospital, and that mothers actually were able to kind of overcome
most of them.
Yeah, most of them. Yeah, but I think actually that's an excellent point. Okay, let's see. I think we had a couple.
Thank
you.
What about if there is a downregulation of the oxytocin receptor? So, as a lot of peptide hormones, when you give exogenously, they cause downregulation of their receptors. So, is any study? No, I'm talking about LH, FSH. When we give it exogenous by injections, then we have downregulation. Is anybody that checked oxytocin receptor? Because maybe they're downregulated through synthetic ingestion.
Yeah, I think actually that is definitely one of the things that makes a difference with that is how it's administered. And that was one of the things that was kind of strange about that Massachusetts study, because they included infusion over labor versus injection. And I think that does make a difference. And yes, I think it would downregulate those receptors.
Now, I have a second question. Is a clear correlation, there's no doubt about lactation and depression. That's a clear correlation. But I have difficulty to understand if it is a really causative correlation. Because in order to do that, you need double random randomized studies, which is unethical to do it. So how we will prove that is a really causative correlation? Because so far it's strong correlation, but that doesn't mean anything.
Right, you're talking about what the girls study.
No, I'm talking about in general depression and breastfeeding.
Okay. Let me see. Right. Let me see if
No. We know that there is a correlation between depression and breastfeeding.
Right.
That's true.
Right.
What does it make it causative correlation?
Okay. I think you're absolutely right about the fact that it's unethical. You can't randomly assign people to that. But I think probably the next best thing is to use the prospective design. And I think that especially if you have a large enough sample that you can control for some of the other things that could be influencing it. For example, we know that middle-class women are more likely to breastfeed than lower-income women. But you can actually, in a large sample, you can control for things like income level. So, it's not the gold standard like the RCT, the randomized trial, but the prospective study, I think, does give us information about, okay, we've got, these women are starting off equal, they're going on this path, this is the thing that's different. And so I think we can get pretty close to a cause and effect.
And there's no animal model. Is there any animal model about this? Is there any animal model about this?
Yeah, there are some animal models, especially looking at the early stress exposure. That's where some of the psychoneuroimmunology has come from, is like, what is the impact of, like, say, for example, stressful birth on animals, and how does that affect their nurturing behavior? And it definitely does. It affects things like, like there have been all kinds of things where, apes have had cesarean sections and they neglect their babies. And sometimes to the point where the babies die. So yes, I think it definitely does. There's a number of animal models. I know Shearson's done a lot of research using animal models too. Yeah. But yeah, Michael Meany especially has done a lot, looking especially at that early sort of stress exposure and the impact. And so yeah, he's somebody. He's up in Canada. He's done a lot of work. Oh.
Excuse me. From your experience, did you see any mothers with depression to harm the babies, to damage their babies? Because I hear a lot about this.
Yeah.
Some doctors, especially in Cyprus, where I come from, when they diagnose depression,
right,
they give treatment, they say stop breastfeeding.
Right.
Thank you.
And we actually have had a lot of mothers who have run into that too. That's the first thing they say, stop breastfeeding. I'm seeing that the tide is turning. We're starting to get some people starting to, maybe let the moms continue to breastfeed. But when I first started in this field, everybody told mothers to stop. That was the first advice. And I think it's kind of like what we heard earlier today. I think where the change comes is by educating our mothers.
Yes, but if he's not treated, she didn't go to the doctor yet.
Yeah.
Can she damage her baby?
Yeah, that's kind of a tricky question.
Sorry.
Interesting. Yes, depression actually untreated can be harmful to the babies. Okay, we have a lot of studies about that. But there's one study that looked, and it's a good study, it's a nice solid study, that looked at the impact of how the mother fed her baby and if that impacted that. And what they found is that the mothers who were depressed but breastfeeding, when they looked at the EEG patterns, the brainwave patterns of the babies, normal. That the breastfeeding was protecting the babies from the maternal depression. Because the mothers couldn't disengage from their babies. They were still interacting with them. Maybe not as much as they normally would do, but it was enough to protect them. But untreated depression is serious, and if a mom doesn't want to take medication, I would encourage you, please go to my website. I have a whole bunch of articles on all kinds of alternatives. Because there's lots of things mothers can do. Exercise, omega-3 fatty acids, sunshine, which you guys seem to have a lot of. So sunshine is good. Vitamin, I would check for vitamin D deficiency. There's a number of different things to look at. But yes, there's all kinds of non-medication treatments that are very effective.
Thank you very much.
Yeah. We've got one back there. Oh, can you pass
it? Thank you. I would like your inputs from your experience on mothers with antidepressive therapy and breastfeeding, because there is a huge controversy in there and a big debate. Many professionals say that if they start antidepressives, they have to quit breastfeeding. And, there is a cloud.
Well, fortunately, we have Tom Hale's book, which I think has kind of made a huge difference for those of us, because it used to be that it was very scary to tell a mom that she could continue breastfeeding on an antidepressant. We know that most antidepressants are compatible with breastfeeding, but some are better than others. Sertraline, paroxetine, those tend to have low transfer rates to the baby, very low. You can't even oftentimes detect it in the infant plasma. And it comes down to one of those risk-benefit things, too, you have to look at, is it's like the risk of the baby being exposed to medication, the risk of not breastfeeding, and the risk of being exposed to untreated depression. And so I think when you look at all three of those things, the risk associated with using the antidepressant, especially one of the ones with the low transfer, that's a better profile. So there's a lot of information. I actually do have a handout on use of antidepressants in pregnancy and breastfeeding. which I'm happy to send you if you want to give me an email. But and those are all free. All those handouts are free, and they've actually already been translated into different languages. So you're welcome to. I'll send you a Word file if you want to make a translation. But we go through the literature on that and kind of how it transfers. It's a little trickier in pregnancy because there is more exposure. But even then, sometimes it's really not safe if a mom's been on antidepressants to take her off during pregnancy, because she can really, go into a very deep depression, and that's where you start getting things like the suicide risk. And to answer your question earlier about, the infant harm, mothers actually hurting their baby, that's very statistically low, fortunately. Those are the cases we all hear about, but fortunately they tend to be very unusual and very rare. But yeah, you do have to worry. I mean, I think maternal suicide is something like the third leading cause of maternal death in the U.S. It's, so that's something we always have to weigh. It's very important. Okay, so I think we're out of time here. Yep, we are past time. So thank you very much. I will see you this afternoon, and I appreciate you.